Thanks.
Welcome. All right. So hello and welcome to the Port Huron Odyssey House's Stigma Prevention Project Educational Series. I'm Alicia Fay. Today's speaker is Ken Huvelman. Ken is a clinical coordinator with Port Huron Odyssey House and is chair of the St. Clair County Substance Use Prevention, Treatment, and Recovery Work Group. He has been working in the behavioral health field for over 9 years, including outpatient SUD services and inpatient psychiatric care. He has a master's in psychology from Montana State University, Billings, and a master's in clinical mental health counseling from Walden University. Additionally, he has worked as a consultant with multiple community organizations to advocate for the expansion of access to behavioral health treatment and for innovative approaches to reduce the community impact of opioid overdose. We ask that you please remain muted for the presentation. You can have your camera on or off, whichever is your preference. The presentation will be recorded and posted on the Flint Odyssey House YouTube channel. Only the live version today will be eligible for McBAP educational credit. If you have any questions, please enter them into the chat or save them until the end when we will have time for a question and answer. At the conclusion of today's presentation, we will share a link to an evaluation survey. Completing this will provide you with your certificate of attendance. And we will get started. Thank you.
Thank you, Alicia. So let me, are you guys able to see screen there? Are you able to see the presentation, Alicia? All right, thank you. All right, so thank you for joining. My name is Ken Huvelman. The name of this presentation is Understanding Substance Use Disorder, or SUD, and How You Can Help. This came about from having a lot of individuals trying to seek a better understanding, very good for the community at large who wants to better understand what a clinical diagnosis might look like, and also for those who may be early or beginning for their clinical careers. So I like to start a lot of my trainings off with the scary part. This is the, what is our need for substance use disorder treatment? What do we have going on in our community? So this data was pulled from SAMHSA's 2021 survey on drug use and health. So for us right now, persons 12 or older across the country that meet criteria for an SUD, almost 30 million people would qualify in the last 12 months for a substance use disorder. For alcohol, you can see some of the numbers there. If you look down at the bottom, you see that overall 46.3 million Americans 12 or older qualified for an SUD over the last 12 months, which makes up 16.5% of the population. So looking at those are people who would qualify for that use disorder. Taking this deeper look at the number of people who reported any use within the last 12 months. Alcohol is the only exception on this one. That is who reported use in the last 30 days. So the alcohol use is within the last month. All of those other ones are the number of people who reported using in the last year. You can see that there are a lot more people using than necessarily diagnosed with a substance use disorder, especially if you look into the cannabis, the alcohol. The one where it does seem to be a match would be in a heroin use disorder. So 1.1 million people reported a use of heroin, while 1 million of those would have qualified for a substance use disorder. So this just goes to show the large number of folks that are currently and actively using, and those that are using at that clinical level. So what this is built up of, we take this look. So as a clinician, I have to be able to diagnose, and if I'm going to diagnose, I need to be able to have evidence. So the very first basic of a substance use disorder is that it is a problematic pattern of use leading to clinically significant impairment or distress occurring within a 12-month period. So this doesn't necessarily mean it had to be recent. This could have been, 6 months ago the use happened, but for the year prior to that, it was there. So we're looking at that 12-month window is that time frame. Another key piece is clinically significant impairment or distress. This is why you can have a large number of people that may be using, but if there's no impairment, no distress, none of those things are occurring, then they may not meet a clinical level for an SUD. So these first four criteria are broken down into what could be considered impaired control. So criteria one, taking in larger amounts for longer than intended. A lot of my examples you'll probably hear be related to alcohol. As you could see in some of those those statistics from before, a large number of our population is using. I think it's 63% of folks with an SUD actually have at least an alcohol use disorder along with something else. I think it was almost like 20 million people have just an alcohol use disorder. So I use that. It's just a common example I go to. So this is the person that may have intended to just drink on weekends, but it trickles into weekdays. I just wanted to have a couple and I turned into 15. So we're looking at how much are they using. Second criteria is that persistent desire or unsuccessful efforts to cut down or control. So again, kind of that this weekend, I'm only going to have 2 and it's not going to be a problem, turns into a 12-pack. We're only going to have 2, it's not going to be a problem, turns into a 12-pack. I'm only going to drink on weekends. I'm only going to drink at social events. I'm not going to drink for the next 30 days. And the person is just struggling really with some of those self-imposed restrictions or limitations or ways that they've tried to cut down or control it. Next is the amount of time or energy spent obtaining, using, or recovering. So if again, this one's a little different in the alcohol world, maybe for an underage person where we spent 6 hours trying to find someone's cousin to purchase for us, or you know, a lot of times in the illicit drug world, these are folks that are spending half their day trying to come up with the money, find the money. Then once I find the money, I've got to find somebody who has it. So I'm making multiple phone calls, maybe driving to, you know, Detroit, driving to the next city over to go find it. Then once I find it, then it's going to take a while for me to go through the process of use. Then I'm using it, and you know, we can look at a stimulant where perhaps I use it and I'm up for 2 or 3 days, and then I sleep for 2 days. This might be the person who drinks, and then you know the recovery is a couple days after because of the hangover. So we're really taking a look at this impaired control. That's these first 4. This inability to use. Some of your 12-step programs, you know, it's that recognition that things became unmanageable. This is some of those clinical signs that your efforts to stop, limit, or control isn't working. Fourth criteria here, craving, strong urges to use. This is the person who it's 3 o'clock and they're considering which liquor store they're going to stop on the way home. Where am I going to have? Am I going to have beer? Am I going to have vodka? What am I going to do? I just can't wait a couple more hours and I can get there. This may be the person who's doing what's known as white knuckling it, where they can maybe go without it, but all day or any trigger really leads to those strong urges or cravings. So these are the first 4 of our criteria. Going into these next 3, so 5, 6, and 7, these are what's known as social impairment. And again, these are coming out of the new updated DSM-5 text provision, so the 5DR, which came out, I think 6 months ago. I'm not sure on the time frame, but came out last year. Not too many changes happened in the new edition. So again, looking at these ones, this is social impairment. This is that use despite the inability to fulfill your obligations at work, school, or home. These will often be referred to as, you know, it interferes with your occupational, educational, or interpersonal issues. If your use makes it so you're calling in, if your grades are failing, you're unable to complete your schoolwork, or you're just unable to maintain a home, your house is becoming disarray, no one's monitoring your children, but you continue to use. It doesn't stop you. Losing your job is not enough to make you quit. Getting suspended isn't enough. Failing a class doesn't change your behavior. You're starting to see some of these problems enter into the different domains of life. This is no longer that you just use because it's enjoyable. It's starting to have some consequences. Next one are those consequences are creating issues with your social or interpersonal problems. So that ability to have a relationship. It used to be a criteria that if someone had told you you had a problem, that counted in the criteria. They kind of said no, because what if you have someone whose problem is worse and they never told you yours is bad? So they got rid of that one. They also, in 2013, they got rid of the need to have a criminal charge. So it's looking at, are we still having persistent and recurrent social interpersonal problems? Every time you drink, you and your significant other fight, but you drink and you keep drinking. But every time it leads to a fight, and whatever it is, it's not enough to cause you to change the behavior. Again, we've kind of lost that control. We see negative outcomes, they're there in front of us. We're either unwilling to admit that those consequences are happening, or we still can't stop despite those consequences. This is the person whose children were removed by CPS, but they just can't stop using. The continued use is there. That use disorder threshold is what we're entering into. The inability to just stop, quit, or manage. So next one, our social or occupational or recreational activities, we either give them up or they let go. We just do them less. This is when the substance use, the alcohol, they start to take over our life. This is the family member that stops going to family functions. This is the person who doesn't go out after work anymore. They used to hang out, they used to do things, they've just kind of disappeared. These are the folks that tend to just feel stuck in their home. The world has shrank. The focus is the use of whatever drug I'm using. It is overwhelming. Some of this could be that the person is spending 12 hours a day in the bar. They used to go home and have a family. They used to have friends. They used to have this. Now they spend all day in that bar. Another one that goes with this sometimes is maybe not given up or reduced, but at times we see where people will manipulate social situations in order to maintain their use. This is a person that won't go to a birthday party unless they can bring their own beer. This is a person who will choose a restaurant for a lunch meeting, but they're going to make sure that the restaurant they choose has alcohol available. I'm only going to hang out at a home where people won't mind that I'm doing cocaine. I'm going to distance myself from people who would challenge my use or would go against what I am doing. So we're starting to see that social impairment. So you have the impaired control, you can't manage it. It's outside of the ability to rein it in. Now we're starting to see 5, 6, and 7. We're starting to look at those significant consequences of it. So next one, again, we're looking into, come on, there it goes. So this is the criteria 8 and 9. We're looking at risky use. This is where we are having use where it's physically hazardous. This one is easily identified. If a client comes into your office and they have a DUI, well, we can all agree that it's physically, not fiscally hazardous, but it is probably also hitting the pocketbook. It's physically hazardous to operate a motor vehicle under the influence of drugs or alcohol. This is a situation where every time I use, I get into fights. Maybe I use so much that I continue to get, beat up, I get robbed, I have these continually physically hazardous situations, but I don't care. This could be the folks that are, for those that are using some of the illicit substances, this might be placing myself in flop houses. I'm going to a home where I don't know anyone who's here. I don't know anything about it. And my plan is to use the drug to get high enough that I'm not able to defend myself. I'm not able to care for myself. And I have placed myself in high risk situations. I'm at risk for sexual assault. I'm at risk for domestic violence. I'm at risk for physical violence or death. And it's almost that I have that lack of concern for my personal safety. The drugs or alcohol have taken control to a level where I don't care. you're right, bad things could happen, but it's either ignorance or just, a disregard for personal safety. Number 9, we are looking at recurring or persistent physical or psychological problems either caused or made worse by the substance. So this is a person who has depression, but continues to use alcohol to manage their moods and feelings. Well, we know that a depressant on top of depression is not going to help make things better. The world is not going to appear sunnier, rosier because of your use of vodka. This is those parts where there is some sort of physical or psychological problem, but you keep going. This is the person who has cirrhosis of the liver damage, hepatitis C, but continues to use, opioids. These are the folks that have just that inability, like the use disorder has gotten so severe, even though I know that it is literally either physically killing me or harming me, or it's just making all of my psychological problems even worse. This is a person with schizophrenia who continues to use methamphetamine. We're taking a person with delusions and entering into stimulant intoxication, which will just exacerbate it and make it worse. This is that part where, again, personal safety, personal well-being is gone. So we've started where we tried to control it, we thought we could control it, we might have lost that. Then we're doing it where it's starting to have interference with our life. It might affect our pocketbook, our housing, our friends, our school. Now we're putting this into where it's literally risking my life. This drug or alcohol has taken so much priority in my life that I'm not concerned about whether or not I'm safe or doing all right. So we can kind of see how these have gone and progressed. The last two here are kind of your pharmacological. What are they doing physiologically to the body? So 10th criteria, tolerance. This is that need for more to have the same effect. This is, I used to drink 1 beer and I felt good. Now I need to drink 6 to feel the same way. The person that smoked a little bit of cannabis, but now is using all of the cannabis. If it's the edibles in that world, the person who used to have 5 milligrams is now, ingesting 20, 30, 40 milligrams. We can look at this one sometimes a lot with the sedatives or hypnotics. Those are often your benzodiazepines or pills. This is the person that took 1 or 2. Now I've got to take 4 or 5. Same with some of our opioids. We just saw that when I was the high I was seeking, I need more. It's also identified by, I took 6. I drank 6 beers and I couldn't tell. This is the field sobriety test, the person who blows a 0.4. And I have seen this. I've had people drive 30 plus miles into my office that I was pretty sure was under the influence, but I wasn't positive. I had my signs, it was likely. So we would breathalyze those individuals. I've seen this a couple times. And the person was able to blow a 0.4 on a breathalyzer, which again, for a early drinker, that's comatose. That is a person who should be hospitalized and should be, being ready to have, interventions placed, because a 0.4, you're not doing good. This is a person who drove their motor vehicle at least 30 miles into an office. Was able to come into the office, carry a conversation. And this is showing me that this person is drinking at such a high level that there's a diminished effect. This is a person that's probably a pint or 2 deep by afternoon and is still maintaining. This is the person that we see in the opiate world. This person might take, 3 or 4 Oxycontins and it has no issue. They hand it to the same person and they give them 1 and that person overdoses. So we see that increased tolerance just by that. So they can take a 30 milligram of something and it just doesn't touch them. And it's through that tolerance. So now we're seeing that you've established some ability to just, again, lack of better terms, go hard. The 11th and last criteria is withdrawal. So a person is entering into the characteristic withdrawal of the specific substances. And we'll take a look at some of those substances and signs of what withdrawal might be. So this is also a substance or something closely related to one is taken to relieve or avoid withdrawal symptoms. You might see this a little bit in the alcohol. This is a person that saves a couple drinks for the morning because they don't want to enter into withdrawal symptoms. If a person isn't able to get alcohol, perhaps they're going to turn to a benzo like an Ativan, a Valium, or a Xanax or something like that, because it will ease the edge. It will take some of that withdrawal off. This is for stimulant use. You'll see this a lot. A person may have a preference for methamphetamine, but methamphetamine was not available. So their choice was to use Adderall, Ritalin. They found some sort of closely related substance to take the edge off of their discomfort. Heroin use may be supplemented with the use of oxycodones or other opioid pills to take the edge off. One of the other ones that this one is often missed in those without a significant or severe alcohol use disorder. To an extent, a hangover is withdrawal. It is just minimal. The person generally feels uncomfortable. They have light sensitivity. They have nausea. They have sweating. They have drowsiness. They have agitation. They may have panic or anxiety. All of those are milder forms of withdrawal symptoms that come from possibly just a binge drinking episode. So this might not be the person that is having significant seizures and needs hospitalization, where they're going to clearly recognize, yes, I've had serious withdrawal, but just having some of those harsher hangover symptoms really would meet that threshold for withdrawal. So this is truly the basics. If you are a clinician, if you are someone in a clinical setting and they walk in and your goal is to identify whether or not they fit a diagnosis, you're looking at these 11 items. So you've got your impaired control. Can they manage it? Can they use when they want to and stop when they want to? Is it having an impact on their overall life, occupational, educational, recreational? Is it starting to dig into their quality of life? Are they using these substances despite negative risks to their physical or psychological health? Are they having significant issues there and it just doesn't seem that they care? And then this one, has the substance use reached a level where it's having an impact on their ability to function after without using, or where they are, able to just consume much higher than normal amounts? So you would go through your screening, you do a standardized assessment, you have a CAGE, you have a SASE, you have a DASH, you have a MASS. There's hundreds of standard assessments you can do to assess someone for substance use disorder. You can do what's known as a biopsychosocial, taking a look at biological, psychological, and sociological factors. You collect all this information. You ask all the questions. You start to develop your understanding of how this person got there. And then you're going to run it through this checklist of symptoms. And this is the part I talk about in any DSM-5 TR diagnosis. In order to qualify, it's a checklist of symptoms. It's a label. It helps us identify what's going on. And if we can start to look at taking out one symptom at a time, that's more manageable. I might not be able to get rid of your label, but these symptoms that you have mean you qualify for this. So once we know we've got the information, we're looking at these things, then we've got to identify the severity. So is this a mild, is this moderate, or is this severe? For those who worked in the field prior to 2013 or really 15 or before, the DSM-4 TR referred to those as use, abuse, or dependence. In 2013, we shifted to the DSM-5 and they went to which is a much more straightforward. It's mild, moderate, or severe. So you have an alcohol use disorder, mild. You have a cannabis use disorder, severe. Stimulant use, moderate. And those are just done by the number of criteria met. 2 to 3 criteria met. So the person has got a DUI, they, lost their job and they have clinical depression yet they continue to use. Okay, we've got 3 criteria. Everything else seems to be okay. Alcohol use disorder, mild. Moderate is 4 to 5 criteria, and then severe 6 or more. The other part is specifiers. So a person may have met that diagnosis, but now they're doing good. I've been working with them for 6 months. I've been working with them for a longer period of time, or maybe they came into counseling, they had their issue, they got arrested in December, they stopped drinking in December, they didn't go to trial until April, they didn't get into your office till later. Well, we like to give people credit for doing good. So we have what's known as early remission, 6 to 11 months of not meeting criteria. So they are no longer meeting those criteria for the use disorder. After 11 months, once they hit that 1 year, it's not like a 12-step program where you may get a cake in a car. You get to be identified as what's called sustained remission. That's greater than a year of not meeting criteria. Now, in the world of diagnosis, there's often the question of how long do I keep calling a person or keep diagnosing a person with a use disorder? In all technicality, you could continue to put it. So if the person had a cannabis use disorder when they were 17 and haven't smoked marijuana since, and here you are working with them at 40 for a different use disorder, you don't have to put that cannabis use disorder on there. Technically, you wouldn't be wrong if you did, but it's sometimes why. With the stigma, with the situations and the stuff that stick with having a diagnosis, sometimes it's weighing whether or not to carry that over. And I only look at that, we did the legal expungement and clean slate. Sometimes it's kind of that realm as well. This person's got 4, 5, 6, 7 years of no use of that. Is it really relevant in my clinical treatment? Maybe a little bit, but probably not. Another specifier is in a controlled environment. So if a person's in jail for a year, they might not meet these. They haven't used, they haven't done these things. That's great. But it's this qualifier or specifier that yes, but that's within a controlled environment. Yes, you can get drugs in jail. I'm not naive. They exist in prisons. You can get substances in treatment facilities. I am well aware of that. But access to those substances is restricted. So it's kind of sometimes coding it with this in a controlled environment, especially if they're going to another provider. It just helps that next provider understand that, yeah, they've got 6 months, but that's because they were in treatment the whole time. And we have some significant concerns still about what it will look like when they're outside of a controlled environment. So those are your basics of diagnosis. You've run through the 11 criteria. Once you identify which ones they fit, you add them up: mild, moderate, severe, and then if there's remission or controlled environment, those get added. So then it's the question of what classes or how do they qualify? Which ones does the 5PR consider? Well, the 5PR has 10 classes of drugs and 1 behavioral disorder in this, I guess it'd be a chapter. So the chapter is the substance related and addictive disorders. You've got alcohol, caffeine. So yes, there is a caffeine, cannabis, hallucinogens, inhalants, opioids, sedatives, hypnotics, and anxiolytics. This is a combination of your barbiturates and your benzodiazepines will fall in here, from Quaaludes down to Xanax. Stimulants, this includes amphetamine, cocaine, and methamphetamine types. So it's not just, it's all stimulants fall into one. This is one most people don't know is tobacco. Tobacco can qualify for a use disorder. And then there's the catch-all for other substances. This would be a person who may be addicted to anabolic steroids. I'm trying to think of some of the other ones they show, for example. Anabolic steroids is one they often put in there. Don't know this would be food because that would probably fit into your eating disorders. And then the last one, this is the one behavioral disorder they stuck in there, which was gambling disorder. So you can kind of see caffeine, gambling disorder, they're a little bit different on here. So caffeine is the only one that doesn't actually qualify for a use disorder. You can have caffeine intoxication or caffeine withdrawal, or you can have caffeine being the reason or cause of another disorder like sleepiness or sleeplessness or anxiety. So you can't have a caffeine use disorder, but you could have caffeine withdrawal or intoxication. Gambling disorder was included as a behavioral addiction, but some of the others that keep kind of getting pushed up are being pushed back against and aren't included. And they've kind of said that's due to a lack of peer-reviewed research on some of those other ones. The ones most people would like to commonly think fit would be your sex, shopping, perhaps internet. You could see video gaming. They are of clinical consideration, but none of those would actually be a diagnosable condition. It is a common thing that goes back and forth. I thought it might happen with the 5TR, but they didn't add those in. Another interesting one is it's tobacco and not nicotine. I don't know if there's a specific reason for that, but if you would look at it, if a person is vaping, they are not vaping a tobacco product, they are vaping a nicotine product. So would that fit? I guess not. So it was really interesting that that's the language they've continued to stick with, is tobacco use disorder. I think that's more of a technicality, but that's the way my head works. So these are your common classes of drugs that can be identified for the use disorders. So then taking this little look at our different substances, what are some signs of intoxication? What does withdrawal look like? So again, since over half of our folks with an SUD have an alcohol use disorder, I think again it was like 63% qualify for an alcohol use disorder, and then another 20% have a drug disorder as well. Signs of intoxication, this one's commonly known. Alcohol is that prevalent when you consider that 30+% of Americans had a drink within the last 30 days. So behavioral changes, they may become aggressive, they may become hypersexual. You're going to see some lability or shift in moods. This is the person that's really happy until they are immediately sad. Impaired judgment. This is the liquid courage, the liquid confidence, or just the lack of prefrontal engagement and doing stuff that doesn't make sense otherwise. Slurred speech and incoordination are also signs of intoxication. Alcohol withdrawal, again, kind of like that hangover, we're looking at sweating, headaches, tremors. Tremors would be kind of like a seizure, but not to that high level. Seizures are common in alcohol withdrawal. Anxiety goes up. One of the huge things to be aware of, so if you're treating a person, if they come into your office and a lot of them like to try to not drink before they come to your appointment because they think that's helpful. I have done a few assessments where the person was normal, was fine, was coherent and doing well at the beginning of the assessment. By the end, you could see the sweat, you could see the nausea in the mouth, and then you could see them starting to just continue to shake where they could no longer hold their coffee cup. This is of note because alcohol withdrawal is one of the few that is lethal. If this person does not get some sort of, well, there's a couple ways to end alcohol withdrawal. The recommended for a person in your office is that they may go see someone for medical intervention. The other alternative is to go find a bartender for alcoholic intervention. Ingesting alcohol will work to reduce withdrawal. A couple of those cases that's been, usually you tell them you need to go to the hospital. If you're going to refuse to go to the hospital, it is recommended that you don't wait. If you're going to drink, this is where sometimes it is told drink on your way to treatment, just to avoid any significant medical conditions prior to. Cannabis, cannabis intoxication, motor coordination, can come with anxiety, impaired judgment again. For some, it increases social withdrawal. Any one of these, there can also be, you will hear the person that will argue that no, I have the opposite effect, which is always possible. You're looking for eye redness, dry mouth, the munchies, or increased appetite. And then with today's potency of cannabis, there is the common perceptual disturbances. This is the person that tells you if you smoke, this music will sound better. If you smoke enough of it, you will see the music sound better. Withdrawal. So again, you can argue with the people on the internet all you want. There are withdrawal symptoms for a person who is going through a detox of cannabis. You're likely to see some irritability, anxiety, difficulty sleeping, restlessness, depressed mood. A lot of these is because the person is some of the psychological impacts of it. It's not as much physical as much as it is the psychological. This person is uncomfortable. They are outside of their norm. For a person going through these withdrawal symptoms, they have probably been using regularly, and not using is new to them. It feels weird. Looking at the next one, come on. Opioids, signs of intoxication. We've got our apathy, impaired judgment. One of the telltale signs for opioid is the constricted or shrank pupils. They get really small. You may see drowsiness. This is often known as nodding out, where a person is having a conversation and their chin just double checks that their chest is there, or they're continually checking that their shoes aren't untied. It's that almost falling asleep standing up or sitting up. You'll see that with kind of that same for the attention impairment. Breathy speech. Just, sometimes it's just a lot of energy to, put those words out there. It's the person that sounds really, really, really relaxed. And there's not reason for it. Otherwise, you're going to pick up like, okay, something might be going on. At certain points of intoxication, you're going to see that shallow breathing. That is why heroin was originally a cough medicine. Thank you to the German folks with the Bayer Corporation for creating heroin. They wanted a faster acting, less addictive form of morphine, so they could use it to make cough syrup, which is kind of like how a lobotomy will reduce your mood swings. You just won't have them. If you don't breathe, you won't cough. So technically it worked. Unfortunately, there was the unintended consequence of potential death. So we don't really use heroin in our cough medicines anymore. Withdrawal symptoms for opioids. This is one where it is not lethal. The common phrase is that many people going through opioid withdrawals would wish they were dying, or at least will feel like they're dying. That dysphoria or depressed mood, muscle aches, diarrhea, nausea, insomnia, sweating, just general discomfort. A lot of times described as having the flu, while also having just been in a major car accident. So you don't feel good and your body hurts. Again, withdrawal for opioids is not lethal. It's just very uncomfortable for the person going through it. Sedatives, hypnotics, anxiolytics. Again, this is your benzodiazepines, your barbiturates, your downers. This might be your Benadryls or things like that people are taking for that extra relaxation or anxiety medications. You're going to see shifts in mood, slurred speech, and coordination, drowsiness. Again, that breathy speech, the person who's just really kind of quiet and almost tired. You may see memory lapses. The person might not remember that they just did something. So these are your intoxication signs. Withdrawal over here. Interesting one with this one, you have some of those same ones, just discomfort, but there may be hallucinations. It's maybe a person who is just a little bit out of touch, may tell some very strange or off the wall stories that they are believing to be real. sometimes along with lucid or highly realistic dreams. Another one on this one is also potentially lethal. And again, it's just the common based on the action, the chemical action of sedatives and anxiolytics. So this is another one that if a person is going to be coming off of one of these medications or one of these substances, medical intervention is recommended for them going through withdrawal. Stimulants, affective blunting, they don't go, they're not happy, they're not sad, they're just there. Increased mobility, increased motor action, anxiety, you may see paranoia. This is often has a person who will have significant weight loss due to a loss of appetite. They may have sweating, heart arrhythmias, hypervigilance is that paranoia, that constantly looking over their shoulder. This is a person you may be having a conversation with and they cannot sit still. They can't not move their hands, mouth. You'll often see a mouth or a tongue being just continually moved. Withdrawal for stimulants, again, not lethal, just uncomfortable and unpleasant. The most unfortunate one for the stimulant user is that a lot of times there is no withdrawal management. Welcome to treatment. You're going to go over there and get started. So some insomnia, some anhedonia, that's the lack of joy. And that's what you tend to see in some of these substances. Those are your common classes. Again, great. Now I know stuff. What does that help me and how do I help other people? So some of the basics is one, take trainings like this. So you guys have already done the first step. Educate yourself about addiction, treatment, and recovery. If you want to help other people, you have to know a little bit about it. Otherwise, the information you give might not be actually helpful. Offering emotional and social support, just being there for them, telling them that they understand you understand what they're going through is difficult. Being there to be a friend is helpful. If you notice on this one, there is one kind of support missing, and that is financial support. Financial support is generally not helpful. They say don't give money, give things. If the person says they need food, you buy them food. You don't give them $20 to get food because we will accidentally turn Burger King into what we wanted. The number of times I have seen where $5 for food has turned into a pint of vodka is common. So just words of encouragement. I think it would be helpful if you went and talked to someone. I think that, maybe this is something that we just can't do ourselves. I love you, care about you. How do I help you? Because I don't know how to do it. So it's encouraging them to get it. Another part is you want that internal desire to change. If they don't want to change, you can yell at them, you can beat them, you can threaten to leave them. All of those things are criteria, right? Physically hazardous, interpersonal relationships exacerbated. All of those things are criteria. It's not enough to stop the use. You have to get that person to change their perspective and change their desire to change. They have to want to do it. One of the huge things for family, friends, or those watching a person struggle with recovery, struggle with substance use disorder, it is a process. Sometimes that process is restarted. That's called a relapse. Sometimes that process is, 6 months, a year, 3 years. The person that you loved and knew before the substances took control is still there. It may take a while for that person to go find them within themselves again. That's this huge part. 90 days isn't going to change everything. Will things change? Yes, but there's still a lot of work to go. And then just like on an airplane, you can't take care of someone else if you don't take care of yourself. So one of the better ways to help others is by helping you. Get yourself a counselor, go to an Al-Anon, get yourself someone to talk to so you can better understand your role in this person's use. There is a social justice lens for SUD. Some of that is the use of stigma-based language. We can talk about those people, junkies and dope fiends. There's a little bit of a hesitation sometimes there is with an addict or alcoholic. Some 12-step programs ask you to identify or commonly have you identify as an addict or alcoholic. Some people prefer to identify as an addict or an alcoholic. The recommendation is to switch to the person first language. Those are persons or people who use drugs or a person in recovery. I was reading an article in our story that was great and talking about a local recovery community organization. And all the captions under the photo said, "This is Jimmy, a former addict." And it just was one of those, why can't Jimmy be a person in recovery? Why are we focused and framing it on his addiction instead of the pathway he is on now? And Jimmy is just a name I chose. So if you're looking for pictures of Jimmy, the former addict, I don't know if they're out there. So it was one of those that I took a moment to write the paper, like just changing that framing of how we talk about people can create differences. Another part of the social justice lens is the difference between sober, clean, and recovery. Those three words do not necessarily mean the same thing. For most, sober is part of the AA program, which means a person is no longer drinking alcohol. It doesn't necessarily apply to other substances. This is the part where there is a California sober, where the only substance you use is cannabis. For the NA program, they use the term clean, which often means a person is abstinent of all drugs and alcohol. Sometimes to be clean, it is required to not be on certain medications as defined by the person who's using the term. That is another one that is also, it is common within that community, in that fellowship. But then what others often say is that it implied that previously they were dirty. So the other variety is recovery. This one is a little more inclusive. This can allow a person to be on their pathway as it is to them. This allows a person to be in a different way. Recently, the National Institute on Alcohol Abuse and Alcoholism created a definition for recovery specifically for alcohol use disorder, but it is fairly applicable otherwise. And their definition of recovery is a process through which an individual pursues both remission from use disorder and cessation from heavy drinking. An individual may be considered recovered if both remission from AUD and cessation from heavy drinking are achieved and maintained over time. For those experiencing alcohol-related functional impairment and other adverse consequences, and this is the part that I kind of stick out that I think applies. Recovery is often marked by the fulfillment of basic needs, enhancement in social support and spirituality, and improvements in physical and mental health, quality of life, and other dimensions of well-being. Continued improvement in these domains may in turn promote sustained recovery. The reason I personally like this one is it feels more inclusive. A person may still, by this definition, use alcohol and be in recovery. This may be a person who is in recovery from an opioid use disorder or a cannabis use disorder, but may choose to use another substance, and it isn't creating difficulty. They've still achieved a better quality of living through their changes in their life. And this one comes down to the same part here, which is the harm reduction versus abstinence. For some people, they may not be able to achieve abstinence. They may still need to use cannabis to manage things until they don't, or they may continue to use it ongoing. So it's that acceptance of a person's path to where they want to live. And one of the counselor's principles is autonomy and allowing that client or individual to have the choice of what their life will look like. Another one that falls into the social justice lens and is often stigmatized as well is medication-assisted recovery. This is the use of medications for opioid use disorder, most frequently your methadone, your buprenorphine or Suboxones, or your Vivitrol. And in some places, those things are not allowed. You may not be allowed to enter into supportive services. You may not be welcome in certain meetings. So it's that recognition that medication-assisted recovery is a thing. Another piece of social justice is the decriminalization of all drugs. This is not the legalization. This is the decriminalization, such as in the country of Portugal, who has been doing it for 23 years, and then the state of Oregon, who I think has been doing it for 1 or 2 years now. The decriminalization just means folks won't be arrested for the use or possession of drugs. Manufacture, sale, and distribution is still not allowed, but a person who is using won't be arrested, criminalized, and penalized. They will be treated and assisted in gaining a pathway towards recovery or whatever it is that they see they need. So it's a different mindset on punishment towards rehabilitation. Treatment looks like basic levels of care. So a person could enter treatment. You've got your detox or withdrawal management. Residential and inpatient is your starting point for many. That's where you're going to stay somewhere. IOP or outpatient are those various levels of care where a person is returning home. Folks that provide treatment in Michigan, there is the Michigan Certification Board of Addiction Professionals, or MCBAP. This includes the Certified Peer Recovery Mentors, which is less common in our state. Most will go with the state's Health and Human Services Certified Peer Recovery Coach. Another part is there is the CADC, which is your Certified Alcohol and Drug Counselor. A master's level is the CAADC. There's certified clinical supervisors and then certified prevention specialists. So these are some credentials of treatment or addiction professional for Michigan. Finding treatment. Where does one find treatment in our area? I did see we've got some folks from all over the state. I don't know if they've all logged in and joined us, but some of these are specific to St. Clair County or Region 10. Region 10 is our prepaid inpatient health plan, the funding source for publicly funded treatment. That first line for publicly funded treatment, so a person with no insurance or Medicaid, at times commercial insurance can call this line too and get pointed in the right direction, but that is that Region 10 access line at 888-225-4447. Other providers include ourselves with Port Huron Odyssey House, St. Clair County CMH, Sacred Heart, Meridian, Renewal Christian, Professional Counseling, and Catholic Charities. Then you have, so treatment is its thing, and then we have the recovery community. Recovery community is what happens outside of or after treatment. You have your Blue Water Recovery and Outreach Center, BW Rock, here in Port Huron. Families Against Narcotics does not have a Blue Water chapter, but there are some in Macomb and across the state. Then you have some of your recovery support meetings, which could be your AA or your NA. You also have Smart Recovery. Smart Recovery is the self-management and recovery training. It's a secular and science-based approach using cognitive behavioral therapy and non-confrontational motivational methods. Another one would be Celebrate Recovery, which is a Christ-centered 12-step recovery program for anyone struggling with hurt, pain, or addiction of any kind. And a third, another pathway would be Refuge Recovery, which is a Buddhist-oriented, non-theistic recovery program. It uses a traditional formulation consisting of the Four Noble Truths and the Eightfold Path. And no, I don't have those memorized. That's what cheat sheets and notes are for. So those are some of the recovery community supports. These can be the ones. The counseling center generally operates 9 to 5. What do you do on the weekends, in the evenings, and where do you find a support group for things to assist? Some of the references obviously coming from the American Psychiatric Association with the DSM, the NIAAA, and then SAMHSA, which is the federal source for substance abuse and mental health services. So that would be what I have. How did I do? 3 minutes to the hour. Nailed it. I'm very proud of myself. Usually I roll over that mark. So that would be the generals of the presentation. I saw some questions in the chat. I think it was Josh. It was a really good question. I saw when I thought about early remission being 90.
Yep.
I have it, and I haven't. I can double check my DSM actually. Got one right in front of me. What good psychology major doesn't have this DSM there? Let's double check because they might have changed it. Nope, doesn't say there. Let's go to the pages. Sorry. And then, yes, I can share that recovery definition. If you go, also, if you do NIAAA recovery definition, it should take it to you on a good Google search. And like I said, it is one I prefer. I feel it's more inclusive, and it's open to those who, it's talking more about quality of life. Has this person recovered and developed a healthier lifestyle that is working for them? While I'm slowly scanning, were there any other? You're right, it is. So met for at least 3 months and less than 12. So it is down to 90. So they have changed that one to a 90-day frame. So early remission starts at day 90 or 3 months. I guess if you have a couple Februaries in there, it's shorter.
We had a question whether or not we could email.
Sure. PowerPoint?
Yep.
Yes, I can share that out. That would not be an issue with myself. So if you would like a copy of that PowerPoint, let me throw the email in here. So it's antistigma@odysseyvillage.com, and I'm putting that into the chat. Any other questions? I see some people coming from behind their dark screens and name bands to cameras on. All right, and I have. Crap, I wasn't supposed to get rid of my copy and save because I was going to use that, but that's okay. So this is, that link there would take you to that recovery from alcohol use disorder. It also defines remission from AUD, and it also defines what they consider heavy drinking. So they quantified it, and it was, I think it was a very significant shift in our field in general to start to take a look that a person could be considered in recovery, yet still using the substance they are in recovery from. It challenges a lot of the recovery community preconceptions, but it also takes a look at this. If it works, does it work? And it is one I can say from a professional standpoint. I've seen it's taken a long time for some folks that are long-term recovery to understand or come around to that one. And it's, but what we often hear people say is if it works for them, it works for them. And if it stops working, they're connected and they know what's there. So it is definitely a shift in what has been around for a while. Any other questions?
Yeah, I got one. When with the criteria, it says you said mild with one to three of the criteria. Now, does the level of the criteria matter? Like if I drove with my child in the vehicle that I was driving under the influence, what about the level of criteria?
Not really. And so that mild is 2 to 3. And the question kind of comes, it's clinical judgment. That would raise a question, is had a failed obligation at home? Is that your role as a obligation at home is to protect and take care of your children? So it could be balanced that perhaps your alcohol is interfering with your ability to be a good parent. a lot of it is, and even in the world of diagnosis, a lot of it is unfortunate because of our American healthcare system. We have to make a shoe fit so we can continue to provide treatment. If you don't have a use disorder, I'm not allowed to see you again next week. So, and this is a very common one in cannabis use disorder. You will see a client who has smoked two joints a day. They have one to wake up, they have one to go to bed. They've smoked 2 joints a day for the last 15 years. They don't drive because they, have this. They haven't had any family issues. They haven't tried to control it, like all these things, because it hasn't had this interference. But for whatever reason, someone told them they've got to stop smoking. Some of them can be tricky to formally diagnose. They're not really showing colors. They've stayed at 2 for 10 years. There isn't this undesired control or efforts to quit because they've never tried to quit till now. So it's understanding again that need for diagnosis. It is at times to identify how to help a person, but it's also to identify how to continue to provide services, to bill for reimbursement. And it sucks, but sometimes that's the reality of it. And it's massaging it while still staying clinically ethical, still staying within those realms, but making it make sense. And the one where I run into it the most is often with the cannabis use disorder. So best source of support for a family dealing with a child with a meth use disorder for several years. Some of those that do have it, that is one of the primary goals of Families Against Narcotics. They offer family coaching. So they can have a coach that truly just works with the family. Al-Anon, I am not positive on their acceptance and openness to, if I don't think they're going to be too harsh against someone whose child is struggling with addiction of any sort. Sometimes what you find with that in those Al-Anon or those support groups is you do develop some fellowship, some networking, and just some understanding of addiction in general. NA meetings are not only open to individuals who are using. There is a difference between an open and a closed 12-step meeting. A closed step meeting is the ask is that it is only for those who are seeking to stop using. A open 12-step meeting is open to the community at times to gain some insight on resources, on connections, on those things. So it's better understanding those. So an open 12-step meeting, an open NA meeting may be a good source to gain some information. And then it is, again, sometimes it is seeking your own professional counseling. You have a child who is, making some life choices that are unfortunate, and you need someone to help process that out. Sometimes an addiction professional, a CADC or a CADC is helpful, but I would believe that a social work professional counselor, therapist could also help navigate those adjustment issues that you have with a child in addiction. Anyone with anything else? Okay, again, we do appreciate you guys coming. This is our kickoff event of our educational series. This will be something that is ongoing. We should be having a similar SUD focused educational session every third Tuesday, noon to 1:30. The registration will start, kind of the same way you found it. We should probably be sharing with those same folks again, our flyers and information. But every third Tuesday of the month from noon to 1:30, we're going to be having an ongoing educational series. This was greatly supported by the opioid settlement funds through the state. So we were welcome to be able to provide this through, I hate to say welcome, because the opioid providers created a pandemic, we have money now. I wish it would have been the other way, that we didn't need the money because they didn't create a pandemic, or epidemic, I suppose, but it doesn't go that way. So, whatever your resource was for how you found it, we should be continuing to share these out and across through either the Port Huron Odyssey House Facebook page, or also through some community partners as well. For those that do need a certificate of attendance, I am placing into the chat. This is a link to a survey. That survey is just some basic questions on how how the presentation was presented. There is no funding coming back to me for good scores, but I will rub those in the faces of my coworkers and say, see, I told you so. So if you can complete that, there will be a spot on the thank you page to download your certificate. Again, this should qualify, this does qualify for McBAP continuing education or regular education for anyone seeking to make a McBAP credential. If that survey doesn't work or things aren't there, I did share that anti-stigma@odysseyvillage.com email, and we can send out any information necessary from there. So again, I want to thank you all for joining. We hope to see you at some of our future events. Thank you.
Thank you, guys.